Bienvenidos a todos esta noche. Qué gusto estar con todos ustedes en este curso de RASH 2.0, un curso en el que van a encontrar no solamente las actualizaciones en el manejo de la alergia a la proteína de la leche de vaca, una entidad cada vez más frecuente en Latinoamérica, sino también casos clínicos donde vamos a encontrar esa ciencia y esas actualizaciones aplicadas. Hoy tenemos el gusto de empezar nuestro curso con el doctor Ian van den Plas. El doctor es gastroenterólogo pediatra, trabaja en Bélgica, es una de las grandes autoridades a nivel mundial, con más de 590 artículos publicados, ha formado las bases sobre cómo debemos manejar muchos de los problemas a nivel gastrointestinal de los niños y particularmente la alergia a la proteína de la leche de vaca.
Hello, welcome to this presentation on the strategies and future opportunities for the diagnosis and management of cow's milk allergy. These are the learning objectives of my presentation. It's about epidemiology and pathophysiology first of cow's milk allergy, and then we will focus on the symptoms, go to the diagnostic challenges, and finally end with the management of cow's milk allergy. So let us start with the definition. What is in fact cow's milk allergy? Well, cow milk allergy is a reproducible, clinically abnormal reaction to cow's milk protein due to the interaction between one or more milk proteins and one or more immune mechanisms. In other words, it's quite a vague definition, which is open for interpretation. But it means also that cow milk allergy is mainly an immune-mediated disease. So children who are allergic to cow's milk do not tolerate cow's milk. But it's not because they do not tolerate cow's milk that the mechanism behind it is an allergic mechanism. Because there are different mechanisms to have adverse food reactions. There can be non-immune mediated mechanisms such as lactose intolerance, for instance, and I will come back to that later, and other mechanisms are certainly also possible. But so cow milk allergy is an adverse reaction, which is immune mediated. And those immune mediated reactions can be IgE mediated or non-IgE mediated. And they can also be mixed IgE and non-IgE, and also cell-mediated mechanisms do exist just as in contact dermatitis. But so cow milk allergy is mainly IgE or non-IgE mediated allergic mechanism. And the IgE mediated mechanisms is relatively easy to recognize because that's the type 1 allergy, and it is characterized by an immediate reaction, very fast reaction, ingestion of the food, and the reaction, the symptoms occur relatively fast within 1 or 2 hours or even more rapid. And anaphylaxis is the typical example of that. And in order to diagnose IgE-mediated allergy, we also have IgE antibodies and specific cow's milk-related antibodies, which will help in the diagnosis of IgE-mediated cow's milk allergy, similar for the skin prick test. But there is also type 4 allergy mechanisms, which is a delayed hypersensitivity, which means it takes several hours up to several days between ingestion of cow's milk protein and the appearance of the symptoms. And there is non-IgE mediated allergy, so skin prick test and specific IgE are not helpful. And in fact, in type 4 allergy, where it's difficult to have a clear time relation between ingestion of cow's milk protein and appearance of symptoms because of the lack of the lapse of time of different days. We have also no additional diagnostic tests. Now, which are the major cow milk allergens in cow's milk? Casein accounts for 80% of the protein in cow's milk, and there are different caseins, and about 70% of the allergic children are allergic to casein, but about 50% are also allergic to whey, and that's then mainly beta-lactoglobulin, which is a protein which is not present in human milk. And so you see that about 20% of the infants will be allergic to both casein and whey, because 70 plus 50 is 120%. But so alpha and beta casein and beta lactoglobulin are the major proteins which cause allergic reaction in the infants. So cow milk allergy overall is the leading cause of food allergy in infants and young children. It's an immune-mediated mechanism, as we already mentioned, and it's occurring consistently with ingestion. And of course, intact cow's milk protein is the first food the infant is exposed to most of the time. And its adverse reaction is the first symptom of an atopic condition in children. Cow's milk allergy in infancy is closely associated with other atopic manifestations, which means that there is 3 to 6 times a higher risk for atopic eczema, allergic rhinitis, and asthma at the age of 10 years if the infant has suffered cow's milk allergy. And cow's milk allergy with gastrointestinal manifestations can be diagnosed in all age groups. So on the other side, although it's difficult to make the close time relation between appearance of symptoms and ingestion of cow's milk, an appropriate timely diagnosis is important, because what has been shown is that a delayed diagnosis has a negative impact on physical growth and development. And duration of a cow's milk exclusion diet, on the other side, worsens the parents' perception of the quality of life in children with food allergies. So early diagnosis and active appropriate intervention is necessary to avoid the risk for impaired growth on one side. So underdiagnosis should certainly be avoided, but overdiagnosis also has negative aspects, as then it will increase the cost of feeding for the infants, which is not needed, and it decreases the quality of life of the families. Now, what about lactose intolerance? Well, primary lactose intolerance in young infants does, in fact, not exist, as illustrated in this chart. In this slide, prevalence of lactose intolerance under the age of 2 years in Japan is non-existing, while it's quite frequent in infants in children above the age of 6 years, it's 85%. But since breast milk is full of lactose, if young infants would have lactose intolerance, breastfeeding would not really be well tolerated. So primary late onset hypolactasia does not start before the age of 5 to 6 years, and certainly not at the age of a few months, which is the age we are talking about. Nevertheless, cow's milk allergy with gastrointestinal symptoms can cause a secondary lactose intolerance due to the damage caused to the gastrointestinal mucosa. So there is some overlap between cow's milk allergy and symptoms of lactose intolerance in those infants with gastrointestinal symptoms caused by the cow's milk allergy. Up to now, I've really focused on cow's milk and the risk of ingestion of cow's milk and developing atopic symptoms, but allergies are complex diseases with multiple causes such as environmental factors, allergen exposure, and also genetic predisposition. So that's why there is a lot of debate in literature, because the allergy symptoms, allergy disease is caused by multiple factors, and it's so always open for debate. So non-dietary factors also play a role in allergy, such as genetic predisposition, as already said, but also the way the infant is born. If you're born by C-section, you have an increased risk to develop allergy. Antibiotic exposures during young age also increases the risk to develop allergic disease. So the epidemiology and pathophysiology is quite complex because it's influenced by multiple factors outside the ingestion of cow's milk protein. Now, which are the symptoms of cow's milk allergy? First, diagnosis again. Overdiagnosis of cow's milk allergy is common, and in the recently published ESGAN position paper on the prevalence of cow's milk allergy, we say that the prevalence of authenticated cow's milk allergy is less than 1%. But authenticated means that there was a positive oral food challenge. Now, if we look at the EuroPreval study, which is considered to be the best study performed in Europe to determine the prevalence of cow's milk allergy, indeed, the prevalence reported was 0.6%, so less than 1%. But if we look at other studies in literature, and we see that two papers from 1973 go from a prevalence of 1.8% to a prevalence of 7.5%. And overall, what is estimated is that the prevalence of cow's milk allergy is considered to be around 3 to 4, up to 5%, as illustrated in this slide. But if you look at the prevalence reported to parents, then you find even figures going up to a prevalence of 10%. So the prevalence of cow's milk allergy should be somewhere between 1% and 10%. And that's why consensus is somewhere between 3 and 5%. Now, which are the major symptoms of cow's milk allergy? The symptoms that occur most frequently are the digestive symptoms, with about 60% of the infants presenting with gastrointestinal symptoms, 30% with respiratory symptoms, 70% with skin manifestations, and 50% with general manifestations. Overall, this is over 200%, which means that majority of the infants with symptoms of cow's milk allergy present with a combination of different symptoms. And this is just an illustration of a child with non-IgE mediated atopic dermatitis due to cow's milk allergy. You see the atopic dermatitis when the infant was drinking normal standard formula, and after 2 weeks of elimination diet with an extensive hydrolysate, you see that atopic dermatitis almost completely disappeared. A study from France, which is called the EVA study, looked at the frequency and combination of different symptoms. And it again confirms that general manifestations such as crying are very frequent, regurgitation is very frequent, respectively 70% and 64% of the infants. Abnormal stools are quite frequent, about 60%, atopic eczema in 30%. And then other manifestations are also quite frequent, like failure to thrive, immediate reactions, rectal bleeding. But if you look at a combination of symptoms, you see that having one symptom only, it's a small group of the infants with cow's milk allergy. It's only about 15%. And 2, 3, and 4 symptoms occur in about 20 to 25% of all the infants. So the vast majority of the infants with cow's milk allergy present with a combination of different symptoms. Again, as we started this presentation, you have IgE and non-IgE mediated allergy. And although there is a major overlap between the symptoms in IgE-mediated and non-IgE-mediated allergy, there are also some differences. So obviously, anaphylaxis is typically an IgE-mediated symptom, but growth failure, iron deficiency anemia, bloody stools, reflux, diarrhea, constipation, atopic dermatitis, colic and crying are all related also to non-IgE mediated allergy. Now, how can we diagnose and recognize non-IgE mediated allergy since the symptoms are aspecific and we have no diagnostic test? According again to data from the RASH study, about 25% of the infants with cow's milk allergy were IgE negative. So it's absolutely recognized in the RASH study that non-IgE mediated allergy does exist and occurs according to these data in about 1 infant in 4. And again, there is no laboratory test that helps to diagnose non-IgE mediated cow's milk allergy. But if we are going to look more in detail in the prevalence of non-IgE mediated allergy in the RASH study, we see that there are different large countries such as Iceland, Germany, Spain, and Greece, where the prevalence of non-IgE mediated allergy is 0%, which means that a lot of healthcare professionals simply do not know about non-IgE mediated allergy, do not recognize it, and that's why the prevalence of cow's milk allergy in the RASH study is likely to be underestimated. Certainly, if we compare this to the report from Carina Venter in 2008, who reported that 92% of the infants with cow's milk allergy had mild to moderate non-IgE mediated allergy. So while in the RASH study, some countries had 0% of non-IgE mediated allergy, according to these data, the vast majority of the children with cow's milk allergy have non-IgE mediated allergy. So the diagnosis of non-IgE mediated allergy is quite a challenge. So how are we going to diagnose non-IgE mediated allergy? Again, appropriate diagnosis is absolutely very important because under and misdiagnosis carry nutritional risk for growth faltering. There are nutritional micronutrient deficiencies, there is a decreased quality of life, there is a financial burden. So diagnosis of cow's milk allergy should be as appropriate as possible. Now, how long does it last before healthcare professionals do recognize the symptoms of cow's milk allergy? This was an observational study performed in several European countries, and it shows you that it varies from 7 weeks in Belgium up to 24 weeks in the UK before healthcare professionals recognize the symptoms as being possibly related to cow's milk allergy. According to the Esbjörn paper, how do we best diagnose cow's milk protein? Well, by performing an oral food challenge, there is broad consensus that this is the golden standard to diagnose cow's milk allergy. There is one negative aspect to it that's that in clinical practice, many parents do refuse that oral food challenge. I will come back to that later. How should you do that oral food challenge? Well, that's illustrated in this slide by increasing gradually the amount of protein, cow's milk protein ingested by the baby. And then for non-IG mediated allergy, it's absolutely necessary that during at least 1 week, the baby should drink at least 200, 250 milliliters per day. But we did in Belgium a comparative trial between two hydrolysates, and both parents had to sign in the informed consent that they agreed to do that oral food challenge in their child. And although both parents did sign that, 25% of the parents did refuse the oral food challenge at the moment it had come because the child was doing very well on the exclusion diet. So in daily life, a lot of parents refuse the oral food challenge. Again, in practice, diagnosis of cow's milk allergy is an elimination diet, cow's milk-free diet during 2 to 4 weeks, followed by reintroduction in breastfeeding and challenging formula feeding. Other diagnostic tests, such as the atopy patch test, the basophil activation test, endoscopy, IgG, and other biomarkers, are, according to our ESPGHAN consensus paper, not recommended at all to perform in routine. In order to try to better diagnose non-IgE mediated allergy, together with a group of European co-authors, we developed the COMIS, which is the cow's milk-related symptom score, which is an awareness tool to make healthcare professionals more aware about the existence of non-IgE mediated cow's milk allergy, and there are now over 40 publications with this COMIS tool. So it's easy to perform score, which is rapid and friendly, and it's an awareness tool. It's not a diagnostic tool, but it can also be used to monitor the response to an elimination diet. So how should you look at it? If the score is very low, less than 6, then the cow's milk allergy is very unlikely. If the score is 10 or above, then there is a possible risk that the child is suffering cow's milk allergy. But again, it's not a diagnostic tool, it's an awareness tool. So that we also agreed within the ESPGHAN group of co-authors for the position paper that the COMIS and its reduction during an elimination diet may be indicative for cow's milk allergy. And while the COMIS might increase awareness and thus favor overdiagnosis, it might as well decrease overdiagnosis, because in order to have a COMIS score of 10 or more, you need at least in 2 organ systems severe symptoms. Now, recently, last year, the DRACMA guidelines were published, so from the World Allergy Organization, and what their recommendation is very similar to that of the ESPGHAN. When you suspect a child with mild to moderate cow's milk allergy, you start a cow's milk protein elimination diet, monitor the symptoms with the COMIS, usually during 2 to 4 weeks. And if there is improvement, symptoms disappear, then you need to challenge. If there is no improvement, then cow's milk allergy is very unlikely. So what are not options for a diagnostic elimination diet? Not an option is, for instance, protein from another animal. But again, what is the practice about the diagnostic elimination diet in some countries? Well, there is absolutely need for consensus, because if you see here in the Czech Republic, 72% of the infant gets an amino acid-based formula, while it's only recommended in severe cases, and 12% get partial hydrolyzed formula, which is not recommended at all in the management of cow's milk allergy. Also, formula from other animals, such as goat's milk, is not recommended at all because a high rate of cross-allergenicity. Up to 80% of the infants with cow's milk allergy are also allergic to goat's milk. So modified goat's milk is certainly not indicated in cow's milk allergy. For the diagnostic elimination diet, classically extensive cow's milk-based hydrolysate or amino acid-based formula were recommended, but now we have also a rice hydrolysate formula. So in the 2024 position paper of ESPGHAN, what do we say? In a breastfed baby, continue breastfeeding, put the mother on a cow's milk-free diet for 2 to 4 weeks and see if the symptoms improve or disappear. If they do not improve, then it's probably not cow's milk allergy if there is a good compliance. If there is improvement, you need to reintroduce the cow's milk protein. The formula-fed baby with very severe symptoms, we recommend to use amino acid-based formula for 2 to 4 months. If there is no improvement, it's not cow's milk allergy. If there is improvement, it's likely to be cow's milk allergy. The vast majority of the infants will have mild to moderate symptoms, and then we recommend to use either an extensively hydrolyzed formula or a hydrolyzed rice formula. So if you use the hydrolyzed rice formula and there is no improvement, it's not cow's milk allergy. If you use the hydrolyzed rice formula or the extensive cow's milk-based hydrolysate and there is improvement, then you need to challenge. If you did choose for the extensive cow's milk-based hydrolysate and there is no improvement, then it's very unlikely that there is cow's milk allergy. But we know that a small proportion, about 5 to 10% of the infants with cow's milk allergy will still react to the extensive cow's milk-based hydrolysate. So if that's the case, you might then think, if there is no improvement, to try an amino acid-based formula or to try the hydrolyzed rice formula. So the ESPGHAN consensus paper again says that amino acid-based formula should only be used in those children with severe failure to thrive, with severe manifestations, and not in 70% of the infants like done in the Czech Republic. So summarizing, what are the options? Of course, milk intact proteins are no options. Extensive hydrolysate with small peptides is an option, but amino acid-based formula and hydrolyzed rice formula are totally cow's milk free. So while with extensive cow's milk-based hydrolysate, you still feed the child small peptides coming from cow's milk, which still might cause allergic reactions in a small proportion of the infants. If you use the hydrolyzed rice formula, you give no cow's milk protein at all, and you have 100% efficacy in case of cow's milk allergy. Soy infant formula should not be used as a first option, but is an option which is acceptable for economic, culture, and palatability reasons. So rice hydrolysate can be considered as an alternative for a diagnostic elimination diet, and hydrolyzed rice formula can be considered also as a therapeutic elimination diet. The role of hydrolyzed rice formula for prevention of cow's milk allergy has not been studied at all. So summarizing, diagnosis of cow's milk protein allergy, elimination diet for 2 to 4 weeks, followed by reintroduction or challenge. But of course, your challenge test will also be positive in the case the child is suffering for functional gastrointestinal disorder. And as already said, although a challenge test is mandatory to diagnose cow's milk allergy, many parents, about 25% in a clinical trial, refuse that challenge test because it will make the child sick again. And if your challenge test is positive, you still have to differentiate between cow's milk allergy and functional gastrointestinal disorders. So that was for the ESPGHAN consensus paper. The World Allergy Organization also published recommendations in 2023, which are absolutely similar. For non-IgE mediated allergy, diagnostic elimination diet for 2 to 4 weeks, for IgE mediated allergy 1 to 2 weeks, and that can be either a hydrolyzed rice formula or an extensive cow's milk-based hydrolysate. That brings me to the last part, the management. So again, the ESPGHAN position paper. Now we focus at the end of the lower part of this slide for the long-term management, which says then for the formula-fed babies or breastfed babies, consider breast milk or the extensive hydrolyzed cow's milk-based formula or the hydrolyzed rice formula or the amino acid-based formula, depending on the tolerance, for at least 6 months or up to the age of 9 to 12 months. That is after the positive oral food challenge. And then you should monitor tolerance development. The Gallen guideline was published in 2022, showing that their preference is extensively hydrolyzed or amino acid-based formula. Strangely enough, they do even not mention rice hydrolysate. They also say to not use soy formula. So this recommendation clearly differs from the ESPGHAN and recommendations and the recommendations from the World Allergy Organization. The Australian guidelines published in 2023 clearly recommend both extensively cow's milk-based hydrolysate and rice protein formulas next to each other as two alternative options. And again, the World Allergy Organization last year published that their recommendation for the therapeutic elimination diet is extensive hydrolyzed cow's milk formula or hydrolyzed rice formula as the first option in the management of cow's milk protein allergy. What after the therapeutic elimination diet, which then, as said, should have lasted for at least 6 months or up to the age of 1 year, re-challenge the child then with the same procedure as the diagnostic oral food challenge, or use the milk ladder. And I just show you here an example of a milk ladder by starting introducing cow's milk protein in a cooked or baked way with very small amounts, but that milk ladder should be adapted to the dietary habits in the different parts of the world. Evolution of cow's milk protein allergies at the vast majority of the infants will become at the end tolerant for cow's milk protein for IgE-mediated allergy up to almost 100% at the age of 3 years, and for the non-IgE-mediated allergy, almost all infants are tolerant to cow's milk protein, according to the Europreval data, up to the age of 1 year. So what's my take-home message? Breastfeeding is, of course, the best. Please stimulate breastfeeding for as many infants and for as long as possible. But not every infant can be breastfed, and so cow's milk-based infant formula is a valid second choice option in the nutrition of infants which cannot be breastfed. Infants do develop then cow's milk protein allergy in 3 to 5%, and there are guidelines which I just highlighted you, published by scientific societies. Now, one of the still difficulties of these guidelines is that they are not well known by general pediatricians and that further education is needed. And this slide just illustrates how some of the statements from the ESBGAN position paper are rejected by Flemish general pediatricians. So further training and education of the general pediatrician is absolutely necessary, because what we need to try to do is to diagnose cosmic protein allergy in an appropriate way and to avoid as much as possible underdiagnosis and overdiagnosis. And that's related, of course, that high prevalence of misdiagnosis because of lack of awareness and training, the non-specific nature of the symptoms, and infrequent allergy testing. But I think that overall, it's the aspecific nature of the symptoms and the lack of an appropriate diagnostic test, which makes the diagnosis and management of cow's milk allergy a real challenge still today for many healthcare professionals and for many infants Thank you very much for your attention, and I will try now to answer your questions.
Thank you very much, Dr. Van den Plas, for beautiful presentation. Muchas gracias, Dr. Van den Plas, por esta presentación. Nosotros tenemos muchas preguntas. Vamos a tratar de contestar algunas y las otras las trataremos de contestar por mail. We will have many questions, but we will ask some of them, and the others maybe we will try to answer by mail. Dr. Van den Plas, en Latinoamérica hay una percepción de los cambios en la incidencia de la alergia a la proteína de la leche de vaca con una tendencia al aumento. ¿Qué factores podrían contribuir a este aumento en el diagnóstico de alergia en la población pediátrica? In Latin America, there is a perception of change in the incidence of allergy in cow milk protein. What factors have contributed to increase about this disease?
Well, it's a very interesting question for which there is no clear-cut answer. I think there are multiple factors. One of the reasons why there is probably an increase in allergic disease are environmental factors. As mentioned in the presentation, the cause of allergy is multifactorial. So it's environment which plays a role, but also the way the infant is born. So if the prevalence of cesarean section increases, for instance, that will increase the risk to develop allergic disease. Early exposure to antibiotics increases the risk for allergic disease. So that's one aspect. And then next to that, I think there is more awareness by the parents who more go to consult the healthcare professional, and probably the healthcare professional himself who is more aware about cow's milk allergy and is more open for the diagnosis. And so diagnosis, it's more frequently than previously. So it's better education, more exposure, more risk factors. So it's multiple factors which cause that increase of cow's milk allergy.
Thank you, Doctor. The second question is, usted habló acerca de la falla en el crecimiento en los niños. ¿Cuál es la principal deficiencia nutricional que se origina en los niños con alergia a la proteína de la leche de vaca y qué estrategias se pueden implementar para prevenirlas? You talk about the growth failure in this kind of child, and what are the main nutritional deficiencies that can arise in this child, and what strategies can be implemented to prevent them?
Yes, well, I think there are, it depends a little bit on the age of the child. The young babies, as long as they're mainly formula fed, there is only a very small risk for malnutrition as long as parents use the appropriate elimination diets with the adapted therapeutic formulas, and as long as the child drinks it sufficiently. So if the intake of sufficient therapeutic formula is there, there is no real risk, I would say, for malnutrition. But a lot of those infants do not like the therapeutic formulas. They are quite expensive. So often parents look for alternative options or give relatively small amounts of the formula and give next to that other feedings. And so the child which is relatively older, which has to continue a cow's milk-free diet, so above the age of 1 year, then there is a real risk for malnutrition, which is then mainly for calcium and micronutrients such as iron deficiency and other minerals.
Thank you, doctor. The other question is, la otra pregunta es, ¿cuál es el impacto en el pronóstico de los diferentes tipos de alergia mediada y no mediada por IgE? What will be the prognosis impact of the different types of IgE or Ig mediated or not allergy?
Yes, well, it's a good question. But I think that the difference between Ig and non-Ig mediated allergy is that almost all infants with non-Ig mediated allergy will become tolerant at the age of 1 year. So then in non-Ig mediated allergy, the risk for later malnutrition is relatively small. But in Ig mediated allergy, it's sometimes only at the age of 3, 4, 5 years that the children become tolerant, and there you have a higher risk for malnutrition, and quite rare, but it certainly exists for some of the children. There is a continuous, an ongoing cow's milk allergy, and they never become tolerant, and they need to be all the time on a cow's milk-free diet, and then it's question of replacing the nutrients from cow's milk, which are again mainly, well, calories, but also calcium and other nutrients. So then a well-balanced alternative diet is very important.
Thank you very much, Doctor. Bueno, it was a so pleasure to have you here. Thank you very much for your time, for very beautiful talk.
My pleasure. Thank you very much. Have a good meeting.
Bueno, y damos así finalización a esta sesión, esta jornada académica. Queremos agradecerle su presencia durante esta jornada e invitarlos, por supuesto, el 29 de abril, martes, continuamos con nuestra sesión de RASH 2.0. Una feliz noche para todos.